So I'm going to give you a little bit of an intro to adaptive interventions, the types of questions they let us ask, which I think is really in line with how James set us up this morning. We really need to be learning more. And so I'll focus in particular, we need to be learning more from our heterogeneity. We need to be going beyond asking what intervention works best on average and thinking about how do we more effectively leverage a toolkit of interventions. And so in that sense, I think also fits in nicely with what David just talked about. So just to start off, I'll put this briefly in the larger framework of precision public health. So I think everyone's familiar with the push towards precision medicine and this idea that we should be taking into account individual variability when we think about choosing the best treatments for people. So as many have pointed out, this principle really extends immediately also to public health. So we could be thinking about a precision public health paradigm that opens the door to both improving outcomes for more people and also improving outcomes for more people under the very real constrained resources that we face. So how does precision public health offer this promise? First, it offers the promise of improving outcomes for more people because for many of our interventions, and this is, I think, particularly true in implementation science, there's variability in the effectiveness of those interventions. So there's variability across individuals, but also variability across clinics, communities, contexts, et cetera. And so the promise of precision public health is that we give each person or clinic or community the intervention that he or she is most likely to benefit from. So David has kind of raised an example of this. You know, that might take into account their preference, but it might take into account all sorts of other things about them as well. And second, it offers to improve outcomes for as many people as possible given limited resources, because there's variability in the individual's underlying risk of having a poor outcome, as well as variability in what sorts of interventions they'll respond to. And so the paradigm of precision public health, I think, really offers the opportunity that we reserve the most costly interventions for those patients who really need that level of intense intervention, and use lower levels of intervention or support for other patients. And so that really is what an adaptive intervention is. So just so you know, to link this to the various literatures that are out there, these guys sometimes go by the name of adaptive interventions, also individualized treatments, personalized treatments, or dynamic regimes in a lot of the statistical and causal inference literature. So just out of curiosity, who's heard of dynamic regimes here? Okay, great. So that's what these interventions do. They're basically rules for assigning a treatment that take into account individual characteristics and attempt to give each person the intervention they're most likely to benefit from and reserve sort of the more intensive interventions for those that need them. So around this time, I suspect many of you guys are saying, wait a second, this is a very fancy name for something that we all of us do all the time in practice. Don't we always sit there and think, well, okay, here I have a person. What are they most likely to benefit from? Here's what I have in my toolkit. I'm going to do my best job to match that person up with the thing that's going to work best for them. Of course, that's what we all do. And we do it under resource constraints. We say, I only have so much money to spend on transport vouchers, so I'm really going to try to make sure that I save enough for the people I think really need that level of an intervention. So absolutely, and I wouldn't argue about that, but I will say that what we can do is we can do a better job of rigorously building the evidence base to take that kind of strategy or use these adaptive interventions. And specifically, there's novel intervention designs, but also novel analytic methods that will let us do that. And these are directly targeted at both developing adaptive interventions, so figuring out what ways of using our existing toolkit are going to give us the best overall outcomes, and also evaluating the comparative effectiveness of these interventions. So I'll give you just a flavor of some of that today. So just to ground our discussion, we'll use just a running example from retention in HIV care. So this is based on joint work with Elvin Gang, our coordinator, as well as Dr. Adeni, who's here as a speaker later. And this just to point out that loss to follow-up after enrollment in HIV care is a serious problem, and patients that experience loss to follow-up experience high mortality as well as a number of other more proximal bad outcomes. So we need better interventions to improve retention in HIV care, and there are interventions that have shown efficacy in randomized trials. So one are SMS text messages or appointment reminders to help patients remember their appointments and also to build a relationship. We can think about transport vouchers or small conditional cash incentives for making your visits, and peer navigators or peer health workers to help you patients navigate barriers to care. So there are these interventions that have shown efficacy in classic randomized trials based on compared to standard of care. But now we're faced with this question of how do we use these in practice? So need, first of all, differs across patients. And this is just a couple graphs, again, from Elvin's work. So this graph over here is just showing that most patients actually are going to stay in care with no intervention. So an approach that says give an intervention to everybody is actually not going to be efficient. And then of those who drop out, the reasons for patients dropping out vary. So some are dropping out due to structural reasons, such as transport, others to more psychosocial reasons, such as relationships with clinic, and others for health reasons. So not all patients need an intervention, and the intervention that's likely to work best for each patient may differ. So how do traditional RCTs tackle this? With that as context, we might think, okay, well, I have these three interventions, say SMS, vouchers, and standard of care. I could do a classic comparative effectiveness study, randomize patients to each of them. And then I would ask, in a classic RCT, how would the proportion retained, say 2 years later, differ if, for example, everyone in the population had gotten a voucher versus everyone had gotten standard of care? So this is the so-called average treatment effect that we classically go after in randomized control trials. And it compares what are called sometimes static interventions. And so to answer that question, because we have randomization, we can just simply compare mean outcomes between arms, and we can do some adjustment if we want to improve the precision of our estimates. But as we saw on the previous slide, these questions are being asked potentially in the context of a lot of heterogeneity in need and response. And so let's just take a quick schematic to illustrate the limitations of that approach. So if we use an RCT to say, compare how patients would have done if they'd all gotten the standard of care versus how all the patients would have done if they'd all gotten a voucher, this is the kind of scenario we might end up in. So we have a heterogeneous population here. Some of these patients, voucher works best, they get a voucher, and indeed some of them are retained. In other patients, SMS would have worked best, but we gave them a voucher, and so they're not retained. They might have been retained if we'd given them a different intervention. So first of all, we're not being optimally effective. Our intervention that we're evaluating, or the question we're asking, isn't a question about the intervention that's helping all the people that could be helped, even with our existing toolkit. And then second, there's this population of people here who are going to succeed with standard of care. So we gave them a voucher, and oh great, they succeeded, but actually we didn't need to use our resources in that way. And then finally, we can think of a population that might not have done well with any of our existing toolkit. And so here again, we're not being optimally efficient. So there's patients who don't need or won't benefit from an intervention, and we're nonetheless giving it to them. So how do we move beyond this paradigm, or how do we ask better questions of our trial data? So I think first of all, we need to define the question. And to start off, we could say, well, how do we better just allocate this toolkit that we have? Or what's the most effective or most cost-effective way to tailor the assignment of our interventions based on the characteristics of patients that we measure? And so this brings us to the concept of an adaptive intervention. That's exactly what an adaptive intervention is. It's a rule for assigning or modifying an intervention based on individual or clinic or community's observed past. And these can include baseline or time-varying characteristics. So now, instead of giving every patient a voucher, an adaptive intervention would say, okay, let's measure something about the patients that lets us figure out who should get what. The patients for whom SMS works best will get an SMS, voucher. Those who would have done fine with the standard of care could still get the standard of care. And this offers a way forward to improve both our effectiveness and our efficiency. Wait a second. So aren't you just talking, though, about, again, giving a fancy name to something we do all the time in randomized control trials? We know about effect heterogeneity. How do we study that in randomized control trials? Well, usually what we do is we say, okay, we study heterogeneity through subgroup analysis. So we know we can't pick too many subgroups because we'll get into multiple testing issues. So let's a priori pick a few subgroups that we think are really going to capture the effect modification or capture the heterogeneity in patient response. And then we'll estimate the average treatment effect in each of these subgroups. So for example, we'd estimate the average effect of vouchers versus SOC on retention among those who live far from clinic, group over here, and those who live near to clinic. And then maybe we say, oh, we only see this effect of vouchers in the patients who live far from clinic. Maybe we should only be using vouchers in that population. Well and good to a point, but there are some serious limitations to this. So first of all, which subgroups do we choose? We might not know a priori which are the most important effect modifiers. And maybe they're not easy to define. Maybe it's not one variable, right? Maybe it's not just how far away from clinic do you live. It's also to what extent are you facing socioeconomic barriers? How old are you? And then even for a simple variable like far, what do we mean by far? How are you going to define far? Second, that we're really limited in the number of subgroups we can look at due to multiple testing concerns. And so this is, I think, the first place where advances in analytics can really help us. So it turns out we can use traditional RCT data, but analyze those data in a different way to ask these questions in a more sophisticated way, or get closer to the questions we really care about. And so there have been advances in machine learning methods. Machine learning methods, though, not just for predicting risk, but machine learning methods for learning the optimal strategy for allocating interventions in a toolkit. So basically what these let us do is ask which rule based on measured characteristics for assigning interventions is going to result in the highest retention. And so one approach to that Mark and colleagues work on is called superlearning. Amazingly, we can use RCT data to not just apply machine learning methods to figure out which complex combination of individual characteristics should be used to allocate treatment assignment, but also use those same data to actually say, if we'd use that rule in practice, how much better would outcomes have been? And so this gets into the methods of cross-validated targeted maximum likelihood estimation. Okay, so again, you guys may be pausing here and saying, that's all nice in theory, but doesn't that actually require measuring patient characteristics that are going to predict response? So can we actually even measure enough on people to distinguish between those who require vouchers from those who are going to do fine with standard of care? Well, I think, first of all, it depends a lot on your question. Maybe, but maybe not. And so then with the last few minutes of this talk, I just want to show how extending this idea to a longitudinal setting can help with this problem. So extending this idea of adaptive interventions or dynamic regimes to multiple time points can help in a couple ways. We could think about reserving low-cost or low-intensity interventions and using them at baseline, with or without doing this additional targeting or tailoring using baseline characteristics. And then also use a patient's initial response to that baseline intervention to decide if that patient needs to be escalated to a higher intensity intervention. Again, with or without additional targeting with time-updated characteristics. So this has a number of effectiveness advantages. It opens the door to further improving our effectiveness because it allows for this possibility of salvage regimens. So if that first low-intensity regimen is insufficient, we can escalate. As well as efficiency in the sense that we reserve those higher intensity interventions for patients who have more need. And so here's just the schematic of how this would be extended in our running example. So first, we use what we measure on people to do our best to assign them to the intervention that's most likely to benefit them. But invariably, there's still going to be people that drop out of care. And so now we respond to that early response by escalating care or escalating the intervention for those patients who need it. So here's a group of patients who got an SMS and did fine. In that case, they stay on an SMS. But here's a patient who got an SMS, and despite our best attempt to give them the thing that would work best for them, they still have an early poor response. And so they get escalated to a more intensive navigator intervention. So by introducing the second line of interventions that adapt based on individual response, we have this ability to improve effectiveness, so improve overall outcomes, as well as efficiency by reserving those high-intensity interventions for patients who need them. So that's all well and good. Once again, though, you could say, well, why are you only escalating to a navigator for everyone? Might there be other options? Could we again use patient characteristics to effectively target not only what initial intervention people get, but also what intervention they escalate to if, in fact, they experience an early poor response? And so here's just a simple single one-variable example of how such a rule would look in practice. So we'll talk about a rule d theta for assigning and modifying interventions, and we're just going to call we're going to use a single variable, satisfaction with care, measured at 2 time points. And theta is going to be some threshold for satisfaction and care level. So we might start and say, okay, let's look at a patient's satisfaction when they start the study. Are they satisfied or not satisfied, according to some threshold theta? Well, if they're feeling satisfied with care, perhaps we assign them an SMS. If they're feeling unsatisfied with care, we assign them a voucher. No problem. So then we follow them over time and we look at their early response. Are they late to care? Well, if they're doing well on their initial intervention SMS, maybe we just keep them on it. If they're doing well on their initial intervention voucher, we just keep them on it. But now they are late to care, so perhaps we could measure their satisfaction again and say, okay, now is it above or below some threshold? If it's above or below, if they're feeling dissatisfied with care, perhaps they need an intervention such as a peer navigator. And if they're feeling their satisfaction with care is higher, then perhaps they would benefit more from an SMS or a voucher. And for those of you who are subject matter experts, I'm not putting satisfaction with care forward as a panacea for answering all of our dynamic regimes, but really just trying to throw it out there as an example of one variable. So this is with one single variable. We haven't even talked about all the sets of things we measure at patients at baseline and all the sets of things we measure at patients over time. But it already gives you a flavor of the types of questions we can ask. And so just to formalize those a little bit so you know what they are.
Really close to time.
Close to time, great, I'm at the end. We can talk about expected outcomes under a specific adaptive intervention. We can talk about what that best adaptive intervention would be. So in our simple example, how would we choose a threshold theta for deciding who should get what? Or even more ambitiously, how can we look at all the things we measure about patients and figure out how to use that to allocate our intervention toolkit most effectively? And finally, what's the comparative effectiveness of that optimal intervention? So if we'd used that rule we learned, how well would people have done compared to more generally, if they'd gotten just standard of care? So to move this to the multiple time point setting, we want to move beyond a single time point intervention and actually introduce this idea of sequential multiple assignment randomized trials, where patients are randomized at baseline. We can look at their initial intervention. Based on early response, they're re-randomized, and we measure an outcome. And so here's an example of just such a trial being conducted with Drs. Gang and Drs. O'Denny here, where patients are randomized to an initial intervention. If they're not retained, they're randomized to an intensive intervention. If they are retained, they're randomized to either continue or discontinue their initial intervention. And we can apply exactly the same methods with extensions to these longitudinal settings to ask these same questions. So just in conclusion then, I think there's tremendous opportunity to learn more from our randomized trials, both our classic trial designs and extending them to these longitudinal sequential randomized trial designs. And then we really are at a point where we can be moving towards a precision public health paradigm. But coming up next, we can do even more. Adaptive interventions are not the same as adaptive designs, but we can actually do both. And so my colleague Mark is going to talk about that.